And Aisha, you can start.
Okay, sir. Good evening, everyone. I welcome all the participants on behalf of Pharm.Doctors. We are privileged to have Dr. G. Raja Amarnath for today's webinar on critical care everywhere. Before we begin, I would like to take the honor of introducing Dr. G. Raja Amarnath. He has done MD, DM, and a European Diploma in Intensive Care from UK. He is also a Fellow of American College of Chest Physician and Fellow of the Royal College of Physicians at Edinburgh and serving as the Managing Director at CIPACA. Dr. Raja Amarnath is a pioneer trained in the field of pulmonology and critical care in India and abroad. He is also a proclaimed Indian professor who teaches undergraduate and postgraduate medical students in several teaching hospitals across Chennai. He is also a senior consultant pulmonologist and intensivist at Apollo Hospitals, Chennai. Dr. Raja Amarnath is a member of national and international bodies like Indian Medical Council, American College of Chest Physicians, European Society of Intensive Care Medicine. He is also an executive member of Indian Society of Critical Care Medicine. He is also the director of several other companies, a certified trainer, and a researcher at several recognized national and international forums around the world. Now I invite our guest, Dr. G. Raja Marnath, to enlighten us on the topic critical care everywhere.
May I?
Yes, sir.
Thank you. Thank you, Miss Aisha, and thank you, Dr. Karthik, for the opportunity and also a very warm introduction. As it is said that I am a doctor. My basic specialty is pulmonology and critical care. We have been looking into this problem of the dearth of ICU services in the remote parts of our country, and we have been trying to connect the dots and trying to attempt to provide the ICU services at the doorstep of rural India. Probably that is what has uh, attracted Dr. Karthik to ask me to present on that. And I'm happy to see that so many doctors of pharmacy are gathered here today to listen to my whatever I'm going to share. I would be running through a brief uh, PowerPoint presentation to take you all through the journey that we have been having for the last, let us say, 5-6 years. So is my screen visible, the PowerPoint?
Yes, sir.
Thank you. Just a minute, I just let me check whether I can change the slides. Give me a sec. So you are seeing my screen, right? Whole screen.
Yes, sir.
Can you see my PPT now?
Yes, sir.
So is it clear now? Can I go ahead?
Please go ahead, sir.
Thank you. So under this topic of critical care everywhere, what we have been doing for last 5-6 years is that to make tertiary care level multidisciplinary ICU services available in rural India. As you know, India has, in 10 years ago, they were saying, 120 crore people. And currently we have 135 crore population in India, which is second most populous country in the world after China. And it is said that, we are actually going to surpass China soon. And by 2025, it has been projected that, Indian middle class population will be actually more than entire US population. So what is the impact? So there are two things happening. Then when you have growing middle class population, which will also show that there is growing elderly population. The population is growing not because of increased birth rate, but because the average lifespan of the people is growing. So what will happen? The elderly population will grow in number. That will place enormous burden on the healthcare, especially on the ICU services, because these are the people who will eventually land up in ICU. Okay, and as we know, when there is growing middle class and growing aging population and growing urbanization, has actually put healthcare in a very very growing phase. And especially these are all the things portrayed before the our COVID outbreak. So it was said that by 2020 onwards, the growth curve of healthcare in India will actually peak, and it will actually take a plateau only by 2050. But it's actually for the next 50 years there will be growth in the healthcare market in whatever the way you say. This is where people who are interested in business of healthcare, but we are more interested in service in healthcare, where we know that according to WHO statistics, around half a decade ago, they said that there is a huge deficiency of doctors, nurses, as well as beds in Indian subcontinent. Whereas the requirement of beds per thousand population is globally is at three beds per thousand population. India was having only zero point 0.9 beds per thousand population. When we look at ICU problem, the deficiency of ICU services precisely, these numbers were taken up recently uh, in 2017 to this is again before COVID. You may see that in for 1 lakh population, where America has been having 34 ICU beds, India has only 2.3 ICU beds. Even China, which is more populous than India, has 3.6 beds per 1 lakh population. India has only 2.3 beds. Even in these 2 beds per 1 lakh population, those are ICU beds, 80% of them are available only in metropolitan cities. So now this is the problem in India. So nothing has changed from 2017 to 2021, except that during COVID outbreak, people have made more ventilators, more cots, more places, and say that there is ICU. And you all know you can't have an ICU just with ventilators or monitors and beds. No, you need manpower to run it. That is where everybody started feeling the challenges. Now, apart from COVID, what is the general problem statement of critical care or ICU services in India? 70% of Indian population, they reside in rural areas or in the suburbs of cities. 70% of specialists, doctors, they practice in cities. This is the major gap. So where there is population, there are no doctors. As simple as that. Now what will happen? You go into the rural area, you talk about ICU services. There is a question about ICU doctors, junior doctors, as well as first of all a dedicated team. Similarly, problem with nurses, problem with technicians. Because of that, what happens, since there is no proper care for ICU available, especially during night times, patients will get referred. I hope you might be knowing right now that most of the referrals happen during night time. Is because during daytime hospitals they try to stretch their capacity to see patients. They try to keep even a marginally sick patient there in the hospital in rural areas. When it becomes night, then you see the real deficiency of manpower. That is when people say that in the midnight they refer out, saying that go to a higher center. So what will happen there? Because of that, patients have to travel, especially during emergency. It is not about just travel during emergency and the expenses incurred during that time, but it is actually about the delay in care, which puts enormous burden on the organ. The more the organ damage before the proper treatment is begun, the more time it takes for recovery. Now, when they reach cities, spend more amount of money, and people leave their work and go along with the patient. 4 5 people have to stay there. This is what is adding to people, to even if they recover, they spend at least 5 to 10 times that that would otherwise should cost for their care. And there are many people they lose their lives. So why is this problem happening? So when you look at overall structure of the healthcare in India, you see the lab diagnostics or medical insurance or even medical equipment, pharma, all these things put together, they don't even constitute approximately 30%. All these things put together. And these are all standardized. You are all from pharmacy background. If you talk about, let us say, cefoperazone, sulbactam, whether it is a Magnex or some other drug, whatever it is the same. Quality will be the same across the pharmacies, at least to some extent. So wherever you are, whether you whether you get it in Chennai or in Delhi or you get it in a rural area somewhere in deeper parts of Andhra Pradesh, the drug will be the same. Same thing goes with the equipment. Whereas 70% of the problem lies with the hospital sector, which is nothing but manpower related, administration related, service related. So that is where there is no standardization. That is the main problem why people are unable to provide standardized quality ICU services, especially in rural areas. If you look at the average ICU in taluk level hospitals, it will be like this: maybe 2 or 3 beds, and they try to keep some few emergency patients there and try to see whatever they can do. How can you have a viability with 2 to 3 beds? It is like saying a flight with 2 to 3 passengers. Imagine the level of financial burden on that. Whether it is one seat in the flight or 260 passengers, you need pilot. No, you need pilot. You need first officer. You need all the crew members. Now to get them, you need to spend money. But if you have only 3 beds, 2 beds of ICU like this, which means you are compromising on the care, which means you can't get a proper team in place, which means your services are compromised. That is the reason why you end up, sending them in the odd hours. That is why people are not able to provide the same care. This is where we, the team of doctors called
Excuse me,
doctors
sir.
and nurses called CIPACA, we started off with a new model of
Excuse me, sir. Sorry to
yes, please.
interrupt you. Actually, we lost your screen. Can you reshare it again?
Oh my God, sorry. Is it visible?
Yeah, it's coming through, sir.
Is it visible now?
Yes, sir.
So where did you lose the? Uh,
Uh, just 1 minute ago, sir. No issues.
did you see this?
Yes, sir.
This average IC in Taluk hospitals.
Yes, sir.
Okay. Now we came out with a model of uh, serving people with our something wrong with this. Can you see my screen?
Uh, we lost your presentation, sir. Can you take that presentation again? Presentation.
Can you see this now?
Yes, sir. No, it's all good.
Clear?
Yes, sir.
Okay, right. So is it clear now? Can you see the next slide?
Yes, sir. Yes, sir.
Okay. So our idea is to make critical care available to patients across hospitals of different levels by making collaborations. Simple. So it is a shop in shop model. Like, you have a hospital in any place, let us say in taluk level, district level, or even in a city level where in suburbs where they need ICU services. and we collaborate with them and we set up an ICU. We partner with them and we set up an ICU. And what do we do? So we set up and manage ICU, provide them the knowledge of cost-effective establishment of ICU, provide them multidisciplinary ICU teams, medical and paramedical. Also in private sector, we do marketing and business development. Wherever required, we provide them telemedicine and tele-ICU. Ultimately, provide international standards of ICU treatment based on whatever the international standard recommendations, of course, for the middle class. So this is one of our ICUs where we go for at least a 10-bedded ICU and maybe 3 to 4 bedded high dependency unit with 24 hours coverage. You may be wondering that when ICU means everybody knows that cost, because in cities, I don't know how many of you are aware of places like Bangalore, Hyderabad, Chennai, all metro cities, the per day cost of ICU will touch at least 80,000 to 1 lakh. So whereas we at the rural areas, at taluk level and district level, when we operate ICU, including ventilator, including dialysis, our cost will be approximately 10 to 12,000 rupees. This is where we brought down the cost to that level, and then we are able to provide those services to people. And it is not a simple one specialty ICU; it's a multidisciplinary ICU. So almost all specialties and super specialties across 22 different areas of disciplines, we can manage those patients. So when we plan ICUs with freehand, we plan like this. There should be hygiene. There will be separate cubicles, so that there won't be spread of infections across patients. A dedicated infection control nurses, dedicated drug nurses, and then bedside equipments, isolation rooms wherever it is required, and central monitoring, and daylight ambience, because for patients to recover, for them to have day and night differentiation is very important. So if we can provide an ICU with where you can have day and night differentiation visible, which means you provide windows properly, that so that sunlight is coming inside. These are all very, very important. So we plan to provide these things in rural areas. And of course, when we say multidisciplinary ICU, it is only a basic level, which means you cover everything. But as you go along, if you see that that area needs more of neurocritical care, for example, we can go into neurocritical care. If there are more accidents coming in there, we can go for trauma critical care. Or if there are more cardiac patients, you go for cardiac critical care. Things like that. You can go into a regional level of burn center, something like that. So these are our goals, that we want to become center of excellence in critical care in those areas. So these are the places where we currently work. There are a couple of medical colleges, Balaji Medical College and Mada Medical College in Chennai. This DMS hospital is located near Kodaikanal. Sumati Hospital is in Villupuram. Sri Kumaran Hospital is in Ottanchhatram, that is also near Dindigal. Sri Lakshmi Narayana Institute of Medical Sciences is in Vellore. And again, another Sri Narayani Hospital is in Vellore, I'm sorry, and the Lakshmi Narayana Institute of Medical Sciences is in Pondicherry. Rajarajeshwari Hospital is in Dindigal. Arogyam Hospital is in Orissa, Sambalpur. The Retteri Kumaran Hospital is in Retteri, Chennai, that is just outskirts of Chennai. Westminster is a big hospital chain that is present in Chennai. Heartfulness is a meditation organization where they planned a COVID care center in one of their meditation areas. So we are running it in Chennai. Unakoti Nursing Care Hospital is in Kailashar, which is near Agartala in Tripura. And the other is MS Multi Specialty Hospital is in Pittapuram near Kakinada, Andhra Pradesh. And we work with Hindustan Hospital in Coimbatore, Apollo Hospital in Chennai. And also we collaborate for academic excellence, like training of doctors in critical care. We collaborate with IMA, Indian Medical Association, and BAPIO, British Association of Physicians of Indian Origin. There are a couple of telemedicine organizations in India and Bangladesh where we work along with them to serve patients. So this is what we are currently. with operating more than 300 plus emergency and ICU beds, 400 plus ICU doctors, 600 plus nurses, technicians, physiotherapists, dietitians, of course, other supportive teams. So this is what we are currently, operating. So we recently celebrated that, we saved more than 120,000 lives across our ICUs in all these places, with accumulating more than 50 lakh hours of ICU patient care experience as a team. This is what the achievements of our team. And of course, we have been recognized as the innovative healthcare provider and best COVID ICU care provider in rural India, and best ICU services in rural India. So you may see some of the photos of the work that our people have been doing across different ICUs. Managing ICU patients in these, uh, most of them are rural areas, some of them are suburbs of the cities. We have this, practice of adding one leaf to each life that is saved. So we have this in every ICU, where this is called tree of life, and we add one leaf, and the patient signs on the leaf that, thank you, like that, they sign when they get saved. So when you keep adding the leaves for the, the plant, that is what gives us actually the happiness that, so many lives that our people are saving in those rural areas, without which, by now, they would have, they would not be alive by now. So this is one of our ICUs. Again, when you see that, an average sick patient, he requires lots of supports. He requires ventilator, he requires monitor, he requires so many pumps, syringe pumps, infusion pumps, a dedicated nurse to care that patient. Whereas this is what the care, the level of quality of care in ICU in any government hospital in India. Even in cities, this is same. This is a person with 40% burns, and this is a burns ward in a government hospital. And as you all know, if there is an epidemic, God forbid, people will be actually cared on the floors in our hospitals. This is one of the places where I worked in UK, that, a pediatric ICU looks like this. This is a general ICU. This is actually a general ICU where the care is given free of cost. Whereas these are our ICUs in India and Africa. The photo that you see, that, something which is really disturbing photo that you see in the bottom left, is a photo of a baby, 1 month old baby, treated in one of the government hospital ICUs in Andhra Pradesh, where baby was bitten. Baby was brought with loose motions and went into severe dehydration and required ICU care. But the baby was bitten by rats in the ICU and died. And of course, government gave some money to them, and somehow matter got closed. But then, when you look at that, the standards of care in either in the government hospitals or even in private hospitals in India, it really pains. In 20 years ago, our roads were like that. Now we have got so much of sophistication, so much of money, budget, and spent interest, spent on the roads, and we all know right now how many great roads that we have. But when you look at the healthcare, it has not changed much. The way that the services are availed in rural areas. I'm not talking about the metropolitan city corporate hospitals. Yes, they have grown, and people who can afford, they're happily, they're affording, and there is a really great improvement in the way the services are coming to the rich people in the cities, especially in the metropolitan cities. Whereas in rural areas, and especially in the government sector, it has not changed much. So we this is what made us move into this direction. Our society definitely needs better ICUs, and the need is very big. At least each taluk needs one ICU of 10 beds. And in India we have 5,000 plus taluks, which means you need so many beds, multiplied by 10 is what is the need of beds. At least what I'm talking is. So we want to achieve at least 10% of this need in the next 5 years time is what is our goal. So we want to go for at least 500 units of ICUs where you bring the standard, the world class standardization in the ICUs, bring technology in the ICUs, paperless ICUs, and connecting the specialist in pan India, training, research, education. If you do that, even if you think you can save one preventable death per day across these places, it means that we are saving at least 1,82,000 lives every year. And if you think that these patients would otherwise spend at least ₹1,00,000 outside when they go to cities, just imagine how much money that we are going to save on the community, on people. So this is what I have to say to all of you. I am really grateful to Dr. Karthik for recognizing us and asking me to present and share with you all about our mission and objectives and how we have been traveling so far. I am really happy and thankful to all of you students who have joined this evening to listen to me about our story. And I would like to stop here, and I would like to take if you have any questions, I would like to take. Thank you so much for your patient listening.
Yeah, thank you, sir. It was an excellent presentation where you touched upon so many aspects, and it was really moving to see few photos which shows the level of care here. So if there are any questions from students, we can take now. You can unmute and ask.
Good evening, sir. This is Sai Sri from Andhra Pradesh, sir. Sir, this is a very beautiful presentation, and your goal is very motivating and also very noble. Sir, I would like to ask, is there any way that we can contribute in this idea? This is very inspiring and noble idea, and it will be honor to contribute something to this idea, sir.
Thank you, Sai Sri. I'm happy to see that you observed and recognized us. See, we are all from healthcare background, right? You people are all doctors of pharmacy. There are many ways that you people can contribute, and because all of us are moving in the same direction. Number one, if you think in your own place you need an ICU, you can connect us with those hospitals where we can try to talk to them and invest on them and establish ICU. That is one thing. Second thing, you can try to rope in some of the fundraising or fund supporting organizations where we can support patients in managing those patients. And third thing is you can actually get associated with us for academic improvement. Dr. Karthik has been saying that you people can get trained in our ICUs in your own discipline, so that the services can be better to those patients. You can actually support our ICUs through your knowledge, so that we do better there. We can serve better to those patients. Like you can suggest on the drugs, the way we should our nurses should manage patients with respect to medication provisions, all these things. And finally, we can collaborate on research. See in rural areas how we can provide better care through research. These are the things that I can think of right now. If you people have any more ideas, you are welcome to come now discuss. This is an area of general discussion. You may feel free to talk.
Thank you, sir. Thank you for answering.
So to add a point here, so honestly, it is really an honor and privilege for you to take time for us, sir. The kind of qualification you have and great work you are doing, there is no reason for you to respond to my messages on LinkedIn. When I reached out to sir, he was so humble to accept and also chat on LinkedIn. Then he connected me to his team. And when I said PharmDisc can involve, and start with basic drug interaction check of all the drugs which patients in ICU receive, and maybe give some suggestions on strategies to minimize ADRs, and maybe develop some IV infusion protocols. So sir was very open. He said, we will be happy to involve and serve our patients better. So, and as sir again said, all of you can brainstorm after this session. And if you have something else in your mind where we can contribute to vision of CIPACA, you are welcome. And at the end, I will be adding, I think I will reinforce what sir has said, and maybe a few other ideas on how all of us can involve in contributing to the great work which CIPACA is already doing. So any more questions? So anybody, if they have a question, you can or unmute and ask. Meanwhile, you can type if you are hailing from a rural background, or if you have any connections in rural. I think most of us are born in rural area. Now we might be living in city. You can use the chat box and type if you hail from village, or if you have any connections from village which needs ICU care. So if anybody has a question, you can unmute and ask.
Mr. Dr. Muhammad Sahal, he asked, how can we involve in the academic training?
Yes, sir. So, yeah, actually, Sahal, CIPACA is already doing a fellowship in critical care medicine to MBBS doctors. Am I right, sir? Is it for MBBS or is it? Yeah.
MBBS,
so, yeah, we were thinking if we can do something like that for Pharm.D, where we train you in critical care pharmacy, which is offered abroad. It is not offered in India. So, sir again expressed interest to help us in that aspect also. So maybe we should spend a little more time and design curriculum, and you will have an opportunity to learn critical care pharmacy. Sir, actually, in the US and other countries, they cannot practice as a pharmacist directly. They have to undergo exams and qualify those exams to get a license to practice pharmacy. And now it has evolved to a stage where there are specific residency programs and trainings in specialties like critical care, cardiology, nephrology, neurology. So in India, we don't have that much. Only 2 or 3 institutes offer that. And your place will be a great place to start such program. And I think they are doing something for nurses also. Only thing that is missing is something for pharmacists, which they have agreed to collaborate and offer. And the other thing is, if there is an ICU, sir has listed out all their ICUs. So if you stay anywhere close, you can visit that ICUs and start learning. It can be a basic internship. And I'm sure based on this interaction, you can imagine that you will get all the freedom to learn, implement, contribute. So unfortunately, we don't have that facility, sir, in our academic training. Though we do internship in big hospitals, we don't have that freedom to involve deeply. So what I will do is, after the session, I will again create a list of all the ICUs where CIPACA already has. Anybody close to that are welcome to go and do internship there.
Dr. Pachayappan has raised his hand.
Yeah, Pachayappan, you can unmute and ask. So any more questions? If you don't have any question, maybe if you can share your feedback, what you felt listening to this talk. So coming to me, I really understood the ground reality of critical care space in India. Very clearly, visually, I have seen it. Sometime back, I might have read it somewhere, but today I understood its the loopholes, gaps, and the work you are doing to fulfill. And in my internship, I have seen many patients, sir. They know that if they continue in that ICU, they will survive, but they fell short of money, spend their entire life saving in 2 or 3 days. They're forced to take their loved ones home just because they cannot afford. And honestly, when I talk to you 2 or 3 times. I'm really like surprised how that quality can be offered at 10,000. And as you rightly said, you are into the service of healthcare and not the business of healthcare. So anybody wants to share your feedback or thoughts? What did you feel?
Good evening, sir. Sir, this is Sayasri again, sir. Firstly, I would say that this is a really, really noble cause, sir. I mean, to think for someone else is like beyond humanity, I would say. And sir, the concept of tree of life is also very beautiful, sir. Like saving a patient and remembering them forever. I think this will become a forest for your critical care unit, uh, sir. And also, it is really an eye opener and very saddening situation to know about the situation of our government hospitals. So that is what I wanted to say. Thank you, sir.
Yeah, Alvin, you can stop YouTube stream so that people might feel a little more comfortable to unmute and share their thoughts. You can stop the YouTube stream.
Okay.
Yeah, so anybody else, sir, how much time do you have, sir? Do you have a few more minutes?